Hi, and welcome back to the next episode of the Dental Implant Podcast. Just before we start, I just wanted to chat with you and let you know that, firstly, for those who have joined the Academy of Implant Excellence, we are just learning so much. I am so excited. The Academy isn't for everybody. The Academy is for people who are really hungry to learn. And what I like to do is I like to speak to you before you join the Academy to make sure that I know 100% that I can give you what you're looking for. So if you'd like to know more about the Academy, please reach out to me. It's a fully comprehensive course, and we're covering all aspects of implant dentistry, from what is an implant all the way up to full arch and zygomatics. We are covering so much, and I'm so excited about it. The feedback that I'm getting from the delegates is they are absolutely loving it as well. We have delegates who are complete novices and others who only deal with implant dentistry, and a whole array in between, including people who've done other courses already. So I'm really excited that the passion that I'm giving back to the Academy is going a long way with the delegates. Some of you have also asked about hands-on options. Well, I'm really thrilled to tell you we do now actually have a hands-on option. And it's not just for dentists in the UK, because I know that some of you abroad have asked as well whether you can do hands-on with me. We can, absolutely we can. So we've got 3 options available for you. We have the basic implantology course. We'll go away for a week. You'll place 20 implants. You have the advanced implantology course, which is a mix of all on X and larger grafts and things like that. Then we have the sinus course where you go away and you will do 5 lateral sinus lifts. So again, if you'd like any more information, please let me know. And also now I'm really excited about this. In September, the 15th and 16th, I'll be holding a 2-day summit on super osseointegration and full arch implant dentistry. Very limited numbers, and it's already partly full. So again, if I can help you with any of these, or if you're interested, please reach out to me, and let's get into the topic of discussion today. So what I thought I'd talk to you about today, and this comes back to what a lot of people say to me, is they see me do immediate implants in cases where they turn around and say, that site's not suitable for an immediate implant. And I turn around and say, well, why isn't it suitable for immediate implant? Oh, because of this, and this. The issue that I have with that is I can do, in inverted commas, impossible immediate implant cases because I've spent a lot of time studying the biology. So once we understand the biology, we can start to understand what rules actually apply and which ones we can actually navigate around. Now, I'm not recommending everybody starts to do immediate implants all the time, because some of my more extreme cases, they are very difficult to execute. But if we understand the biology, then we can get some pretty incredible results. There's a couple of techniques that I wanted to speak to you about today as well. So I am going to do a separate podcast on socket shield, partial extraction therapy, which ironically, partial extraction therapy has a completely different meaning in the US than what it does in Europe. So in order to keep things simple, when I do that podcast, then I will speak purely about socket shield. But sometimes depending where you are, the terms are interchangeable. But one thing I wanted to discuss with you today is, let's take these cases where people turn around and they say to you, you know what, you need to have at least 1.5 to 2 millimeters of bone, buccal bone. And if you don't have that, then you're not suitable. Then the patient isn't suitable for immediate placement, because that thin amount of bone is going to disappear, which it will. They said that thin amount of bone is going to disappear, and therefore we have to do a delayed approach. Now, forgive me if this is old hat to some of you, but some of you who, of some of the listeners, you haven't been placing implants as long. And there is a concept called the bundle bone theory, which, if you don't know about it, is something that you need to, something that you certainly need to look at. Bundle bone theory has been quite around for quite some time now, and this explains why we get that thin bone, why we get that resorption so quickly. And the answer is really simple: is the very thin amount of bone which is immediately adjacent to the tooth. By thin amount, I mean 3/4 of a millimeter, there or thereabouts. That is actually what's referred to as bundle bone. Embryologically, it's not actually related to the alveolar bone at all. It's related to the Hartwig's root sheath. And what this means is it's related to the tooth, not related to the bone. So when you remove a tooth, that thin bundle bone, because it's relying on the tooth and developmentally it was part of Hartwig's root sheath, once the tooth's gone, that bundle bone is 100% going to disappear every single time. Now, this is why socket shields work so well, because you are preserving that part of the tooth, which is therefore preserving the bundle bone. That's why you get absolutely incredible results with socket shield. But let's say that the patient isn't suitable for socket shield. We need to do something else. The question is, what do you do? Okay, so historically, what a lot of people will turn around and say is that what you need to do is we need to remove the tooth, wait several weeks for the soft tissue to form and for that bundle bone to disappear. And then we can go back in and we can place an implant and do simultaneous grafting. Here's a concept for you. If you know that that bundle bone is going to disappear, why not just get rid of it to start with? Why not raise a flap or even do it flapless? You can regenerate everything internally. If you know that the bone is very, very thin and it's going to disappear, why not just remove it and treat it like a 3-4 wall defect? Okay. And I've done this plenty of times where I could feel that the bone's thin, patient wasn't suitable for socket shield. I've removed the tooth, I've raised a small flap, and then I've just placed the implant, grafted, membrane, no membrane, depending what type of technique that you're using, what biomaterials that you're using, and place the implant, and we're off to go. And you know what? The body doesn't know any different. So the body only knows different when you take the tooth out. And then it's like, okay, the bundle bone's here. I've got to get rid of the bundle bone. It's going to take me weeks. But if you help the body, and it's like, okay, you know what? The tooth's gone. You know what, buddy? How about I get rid of this bundle bone as well for you? The body just goes, okay, cool. What's left? What do I need to regenerate? And this is one of the reasons why I don't believe that when you have thin bone that you necessarily need to delay your approach. You really don't. You really don't. What I would say as a word of caution is this type of approach, it does require a higher level of skill and confidence. So you need to respect the fact where you are in your learning cycle. So if you feel that this is something that you can do, understand what we're doing is because we're getting rid of the tooth, we know that bundle bone is going to disappear. Instead of waiting for it to disappear, just get rid of it. It's really, really, really quite simple to do. Okay. Another technique that I wanted to talk to you about is something called immediate dentoalveolar restoration, which is a concept by De Rosa and his team over in Brazil. It is actually a very, very clever technique. What do we do in this technique? We go to the tuberosity. You can get a curved chisel, raise a small flap, and you can take a little bit of bone from the tuberosity. You shape that to the size of the alveolar defect, and you wedge it in place, flapless, so you're maintaining the blood supply. And then what we do is you place your implant behind it. Okay, so De Rosa has a lot of data going back probably about 15 years now on this technique, showing very, very good, very predictable results. What I would state is, because I have done a lot of full arch and because I've placed a lot of pterygoid implants in the UK, and there's a reason for this, in the UK, the quality of the bone in the tuberosity is really not fantastic. It's generally very, very poor. Now, there are ways around this. If you harvest more bone, you can compress it to get the cells a bit closer together. But one of the reasons why the quality of the bone in the tuberosity is poorer in the UK is basically the weaker sunshine that we have over here in comparison to Brazil. And what that means is vitamin D levels are generally very, very low. Generally very, very low. If you've got a skin tone similar to myself or even darker, we're guaranteed to have vitamin D deficiency. Even our Caucasian patients will have vitamin D deficiencies, particularly in winter. And this is a really, really, really big problem. So I was taking 12,000 IU of vitamin D3K2 every single day for about 2-3 years, because I had a blood test done. I found that my vitamin D levels were low. So I to start with, I started taking 4,000 IU, which I thought was huge. I had a blood test done again 4 months later, and there was virtually no change at all. So I thought, right, let me increase it. So I increased the concentration to about 12,000 IU every single day. Then I didn't have another blood test done for about another 3 years after that. And what I found is that when I eventually had a blood test done, I was still barely on the lower side of normal. And what I ended up having to do is I gave myself, I arranged for an IM injection of vitamin D3, 300,000 IU. And that is what has corrected my levels. It took an absolutely colossal dose. So we need to be mindful of this because we've discussed about vitamin D in the past and how it impacts and how it impacts the metabolism of bone. And this is something that I've discussed at length with my delegates. It's not just vitamin D, it's cholesterol, it's oxidative stress, it's systemic inflammation, it's the combination of medications that these patients are. They all kind of like start to add together. It's very much a balancing game. So the IDR technique is absolutely beautiful, but I do apply it with caution in the UK just because of the quality of the bone that we actually get at the back there. The other technique that I like to use as well is I'll harvest autogenous bone at the same time as implant placement, and I will use the Curie plate technique. Now, we don't always have to go to the external oblique ridge, although that is kind of like standardized practice. What I mean by that is if I'm working at the front of the mouth in the maxilla, I absolutely love going to the palate to harvest bone because you get such good quality bone there. So in my mind is if I was to go to the palate, it's less traumatic because we're already kind of working in that area as opposed to going to a separate donor site in the mandible. Now, the proviso that I would say there is all of this is done off diagnostics of CBCT. So if I do need to go to the mandible to harvest bone, I will go to the mandible to harvest bone. So I just want you to think a little bit, kind of like, these are my thought processes which I'm going through when I see cases where there is no buccal plate or very thin buccal plate. I'm looking at it and going to myself, what are the biological ways that I can regenerate this predictably? Okay. And then the question is, do I have the clinical skills to be able to execute this? And if I need to, then I can do that. Sometimes the patients don't want to. And just because I can doesn't mean I do. So again, let's go back to what we were talking about a few moments ago. Patients who are metabolically compromised or patients who have had, who are under high psychological stress, we know that they won't heal the same. So because they don't heal the same, quite often I will slow down their treatment. I will increase their overall treatment time. I will phase their treatment. Sometimes patients are just like, I want to have it done. I can't pay for it all up front in one go, or can we stage it? And we can stage it for monetary purposes as well. So it comes down to balancing what's the right thing for the patient and what we're clinically capable of doing. And it's always patient orientated. It's always patient centered. Okay. So another thing that we can do as well is when we are undertaking these immediate type procedures. Let's say you've got a case where there is no buccal plate and the patient doesn't want to have autogenous bone harvest. What I quite like to do in those cases is I will do a tunnel approach technique. So I'll use kind of like a vista type incision, and I will slide the membrane in laterally. I can graft behind it, and I can still put the implant in at that same visit as well. So this is what I'm trying to express to you, is that there are a lot of clever ways that we can do these in inverted commas impossible cases, but they are actually possible once you understand what's happening with the biology. Is if you try doing these cases where you've got that really thin bone and you don't remove that bundle bone, then the whole case is going to collapse. Okay. Whereas if you know what's going to happen, you're like, okay, you know what? Let's do that. And what we'll do is I'll get rid of the bundle bone, I'll regenerate it. Then it ends up being quite a predictable procedure to do. The other thing that I would mention as well, and this is a grossly underlooked aspect of immediate implantology, and this is soft tissue grafting. So yes, absolutely, we can use things like mucoderm and other dermal matrix-based products. They do thicken up the soft tissue. Now, what I would do is I would qualify that statement by turning around and saying that when you use autogenous tissue, wherever you harvest that autogenous tissue from, you take the genetic coding from that place and you transfer it to your donor site. This is really, really important in high-end aesthetic cases because it can be the difference between make and break. A lot of people focus solely on regenerating the bone and they skip the regenerating of the soft tissue. It is in a lot of cases the soft tissue that's the problem. If you do not have enough good quality and quantity of soft tissue, then your case is going to be an aesthetic failure and you run the risk of developing problems long term. Now, how important is soft tissue? Well, there's something when we do full arch implants, something called a palatalized approach. And what the palatalized approach effectively is this is in a thin ridge case where you protect the bone buccally and you deliberately place the implant more palatal and you don't mind having threads exposed on the palatal aspect. And you don't graft it. You just put the soft tissue back over the top. Do you know what happens? Absolutely nothing. Do you know why? Because of the quality of the soft tissue covering the implant. It's that simple. So there are two sites where you can harvest from in the palate. And it depends what type of graft that we're doing. So you can harvest the connective tissue from the palate. We can go to the tuberosity, and if you need something that aesthetically is a good color and you're doing things like vestibuloplasties, we can do a strip graft from the buccal, kind of like around the molar positions as well. So the reason why I'm saying this is I've seen a lot of cases where the bone's been regenerated beautifully and the implant's in a good position. The restorative is really, really nice, but we've had papilla loss. And the patients come to me and they turn around and say, can you redo my implant? And I very simply turn around and say to them, you know what? We do not need to redo your implant. The implant's been done very, very nicely. What we need to do is we need to increase the thickness of the soft tissue. When we do that, then we can, not only are we improving the prognosis and health of the long term for these patients, but aesthetically that is something that's really, really important, that having this really thick soft tissue is really critically important. What I would say is, in immediate implant cases, there is data to suggest that when you use autogenous soft tissue to harvest and you augment the soft tissue, whether you think it needs augmenting or not, that it doesn't improve the outcome of the implant in terms of prognosis long term. But what we do is we generally get better aesthetic outcomes. We generally get better gum tissue stability. And this is something that I do in a lot of immediate implant cases. And I will just turn around and say to the patient that, look, without doing this, you're going to have a compromised result. And it doesn't take long to harvest the soft tissue. So if I'm taking it from the palate, it's probably about a 2-3 minute job. If I'm taking it from the tuberosity, it's even quicker. And then you just have to de-epithelialize it and get it into the anterior position. So these are my thoughts on immediate implants and why, when people turn around and say to me, you have to have a minimum of 2 millimeters of bone around a root if you're going to put in an immediate implant. The entire buccal plate has to be intact. It really doesn't. What we need to do is we need to understand the biology. And once we understand the biology, we know what's true, what's not true. And then we can investigate some of these more nuanced, some of these lesser well-known treatment modalities and techniques. And we can apply them and think to ourselves, biologically, that makes sense. Biologically, that's going to work. Well, actually, you know what? That doesn't make any sense why it would work. This person's just making it up. And so when we understand the biology, when we understand what's going on, and this is why I very much drum home and why I teach not so much how we do things to start with, but why we do things to start with. The biology is really important. This is quite often, I've had people approach me and ask me my opinion, and they turn around and say, oh, I've got this case. Would you mind looking at it? Sure. Well, I'm thinking about doing this or this. What do you think? I said, well, they'll both work for slightly different reasons. You tell me what those reasons are, because I like to get people thinking. So this is why I think a lot of cases where people get told, there has to be certain parameters whereby you have to do immediate implants. It's not the case. It's really not the case, because we've got great techniques, great materials out there. As long as we understand what the biology is we can apply the appropriate biological and surgical principles and get fantastic outcomes for the patients. Thank you very much, everybody, for tuning in. I deliberately kept this a little bit shorter today. I will see you again soon, and I will promise right now, right here, I'll get the next one up in about a week. Okay? Take care, everybody. Speak to you again.